You have a patient coming in with epigastric pain, intermittent melena, and the pain is often worse with an empty stomach. Try start thinking about duodenal ulcer. This patient could be having unopposed gastric acid that's emptying into the duodenum, which is causing the pain when the patient is on an empty stomach, and it usually improves when you have food. The reason behind this is because you have alkaline fluid that's being secreted into the duodenum when you eat, which makes the pain subside. Pathophysiologically, the duodenal ulcers are usually actually located in the anterior and posterior wall of the duodenal bulb, and as far as step 1 is concerned, it's important to know the distinguishing feature between erosions and ulcers. Erosions are more superficial than ulcers, and ulcers involve damage to the gut, the gastric mucosa, extending beyond the muscularis mucosa into the submucosa. Super high yield. Two major contributing factors for the development of peptic ulcer disease are GI infection with H. pylori and NSAID use. A lot of the times on question stems, they'll say a patient takes a myriad of medications, and somewhere in there they're going to add Advil or ibuprofen. And if they add in abdominal pain, start thinking about peptic ulcer disease. Now, 40 to 70% of duodenal ulcers, that's H. pylori, while 25 to 50% are gastric ulcers. People who have chronic NSAID use, they have a fourfold risk of developing PUD. Let's say a patient really needs chronic NSAID therapy, then you have to start thinking about acid suppression medication for ulcer prevention. There's other risk factors that you have to look out for: smoking, heavy alcohol use, glucocorticoids, and caffeine. Things like diet. People who don't have a very high intake of fruits, vegetables, and fiber, or vitamin A can be more susceptible to PUD. There's also psychological factors that can cause it. That includes anxiety, stress, or even PTSD. Now, just because someone who takes chronic NSAIDs and has no abdominal pain, it doesn't mean that they don't have peptic ulcer disease. 70% of patients with peptic ulcers don't have any symptoms, but if they do, they describe it often as a gnawing or a burning pain. To distinguish the differences between a gastric ulcer and duodenal ulcer, for the gastric ulcer, you want to see that the pain increases shortly after eating. It causes weight loss because of this. The patient no longer wants to eat. But for duodenal ulcers, as we mentioned earlier, the pain is relieved when they have food intake, so they often have weight gain. Your approach at first for a patient coming into clinic, non-pharmacological measures and close follow-up is important, but if you're really suspecting PUD, you want to do the H. pylori test and treat strategy. So let's say if the H. pylori test comes back positive, you want to do eradication therapy with antibiotics and PPI. You continue the acid suppression medication for 4 to 8 weeks. Now, if it's negative, you do a trial of acid suppression medications anyways for 4 to 8 weeks, and then you reevaluate the patient. Oftentimes, even with therapy, you can give cytoprotective agents like sucralfate. These protect the GI mucosal layer, or even misoprostol, and always tell the patient to have non-pharmacological measures like restricting alcohol, smoking, caffeine, and avoiding stress. Definitely discontinue NSAIDs if they can, and avoid eating before bedtime. Now, if they have refractory symptoms, you can do surgery like vagotomy, where you do a division of the anterior and posterior vagal trunk of the vagus nerve, or you could do a partial gastrectomy. The most common complication is bleeding, so look for hematemesis, melena, anemia, and orthostatic hypotension.